Good morning. I'm Dr. Tara Arvind, working in the Department of Oral Pathology and Microbiology, Amrita School of Dentistry. The topic of my discussion is benign osteogenic neoplasms of bone. I'll be discussing it under the following headings: normal histology of bone, bone neoplasms and its classification, benign osteogenic neoplasms of bone that includes osteoma, osteoid osteoblastoma, and I'll be concentrating on the clinical, radiographic, and histopathological features. Coming to the general structure of bone, the outer part of the bone is composed of closely packed osteons or Haversian system. If we take one osteon, centrally there is a canal, and that is known as the Haversian canal containing blood vessels, and surrounding that there will be concentric deposition of organic matrix, bony matrix, and they are known as the concentric lamellae. So numerous osteons pack together to form the compact bone. This compact bone encloses within is the medullary cavity, and this medullary cavity contains the second type, that is a spongy or the trabeculae bone, in which the bone can be seen in the form of trabeculae or bony plates or bars. So basically there are two types, compact bone and the spongy bone. Though the bone vary in size and shape, the cells of the bone are the same. Osteoblast, that is the bone forming cell; osteoclast, bone resorbing cell; osteoprogenitor cell, they are mesenchymal stem cells or precursor cells that has the ability to differentiate into osteoblast, and osteocytes are entrapped osteoblasts within the bony matrix. This is the histopathological picture of the compact bone containing Haversian system and concentric lamellae, and this is a picture of a spongy bone where the bone is arranged in the form of trabeculae enclosing the marrow tissue. So coming to the bone neoplasm. So what is a neoplasm? A neoplasm is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissue, and it persists in the same excessive manner even after the cessation of the stimuli that evoke the change. The neoplasms can be of two types, benign and malignant. If the tumor remains confined and doesn't spread into surrounding tissue, then we consider it as a benign. And if the tumor invades into the surrounding tissue and metastasizes or spreads through the blood or lymph, then it is malignant. This malignant can again be divided into primary and secondary. Here we are dealing with a bone neoplasm. So primary malignant neoplasm is basically the neoplasm that is arising from the bone. And secondary is the neoplasm, it is arising from some other part of the body, and then it is metastasizing or spread to the bone. So the most common sites from where the bone mets occurs are the breast, prostate, lungs, thyroid, and kidneys. WHO has classified bone tumors into chondrogenic, osteogenic, fibrogenic, vascular tumors, osteoclastic giant cell rich tumors, notochordal, other mesenchymal tumors of bone, and hematopoietic neoplasms. So today I'll be discussing about the benign osteogenic neoplasms of bone. That includes osteoma, osteoid osteoma, and osteoblastoma. So osteogenic means bone forming. So the neoplasms, these neoplasms, basically it forms bone. Coming to osteoma. Osteoma is characterized by the formation of mature compact or cancellous bone. Excessive formation of mature compact or cancellous bone. They exclusively seen in the craniofacial bones, especially in the paranasal sinuses. If the osteomas arise on the bone surface, it is known as periosteal, peripheral, or exophytic osteomas. And if it is seen within the bone or within the medullary bone, then it is known as endosteal or central osteomas. Sometimes it can be seen outside the bone. For example, it can be seen within a muscle or dermis of the skin. Then it is known as the extraskeletal osteomas. So those extraskeletal osteomas that is present on the dermis of the skin, it's known as osteoma cutis. Clinical features. Osteomas of the jaws are often seen in young adults. The most common gnathic locations are the body of the mandible or the condyle. If it affects the body of the mandible, the most common location is posterior to the premolars. Periosteal osteomas are osteomas that arise from the surface of the bone. So usually they will be clinically evident and they appear as polypoid or sessile masses on the bone surface. Whereas endosteal osteomas are seen like that arise within the bone. So it may not be evident clinically unless they are large enough to cause expansion. There is seldom any pain associated with this tumor. And when paranasal sinus osteomas are considered, the most common sinus involved is the frontal sinus, followed by the ethmoid and the maxillary sinus. Usually, the sinus osteomas are asymptomatic, but in rare cases, it may expand into orbital structures and may result in proptosis, diplopia, and decreased visual acuity. Infrequently, intracranial extension can cause meningitis, cerebral abscess, and intracranial mucocele. Coming to the radiographic features, radiographically, osteoma appear as circumscribed sclerotic mass, well circumscribed sclerotic mass. So when we see such a radiographic picture, the differential diagnosis considered to be the condensing osteitis and cementoblastoma. So condensing osteitis also, they would be a sclerotic mass, but since it is a type of osteomyelitis, condensing osteitis will be always seen associated with a carious or an infected tooth. So this is how we differentiate the condensing osteitis from osteoma, whereas osteoma is a benign neoplasm of bone. Cementoblastoma, this also appear as a well circumscribed sclerotic mass, but this is a benign odontogenic neoplasm in which the lesion or the sclerotic mass will be fused with the tooth root. And the outline of the root also cannot be differentiated, or it cannot be the outline cannot be clearly visible because the tumor is fused to the root. So that is how a cementoblastoma is differentiated from osteoma radiographically. And if the osteomas, when it appears in the condylar region, it is very important to distinguish this osteomas from condylar hyperplasia. Because osteomas are benign neoplasm, whereas hyperplasia is not. So how do we distinguish this condylar osteomas from condylar hyperplasia? In the case of condylar osteomas, it appears as a lobulated mass, whereas in hyperplasia, although when we compare it with the opposite side, the size of the condyle increases, but it retains the shape. So in condylar hyperplasia, basically the condyle retains its shape, but in condylar osteomas, it appears as a mass, polypoid mass. It's lobulated. It appears as a lobulated mass. Sorry. Histopathologically, it appears as normal appearing, either compact bone or the cancellous bone. So histopathologically, when we see the picture of a compact bone, then we call it as a compact osteoma. And if we see the picture of a cancellous bone, then you type it as cancellous osteoma. And the osteoblastic activity also will be very prominent in the case of osteoma. Treatment is conservative excision is appropriate for large or symptomatic osteoma. So Gardner syndrome is one of the most common syndrome that is associated with the multiple osteoma. So Gardner syndrome, it's a very rare disorder characterized by multiple osteomas, intestinal polyps, as well as various abnormalities of teeth, skin, soft tissue, and other sites. It is an autosomal dominant disorder caused by mutation in the adenomatous polyposis coli tumor suppressor gene. 90% of patients with Gardner syndrome demonstrate skeletal abnormalities, the most common of which are osteomas. The osteomas usually are noted around puberty and often become evident before the intestinal polyps. Most patients demonstrate 3 to 6 osseous lesions. The presence of multiple osteomas may lead to an early diagnosis of Gardner syndrome. Colorectal polyps typically develop by the second decade of life. These colorectal polyps are adenomatous and, if left untreated, ultimately transform into adenocarcinoma. Dental abnormalities occur in about 22% to 30%, and it include odontomes, supernumerary teeth, and impacted teeth. Most patients show one or several epidermoid cysts of the skin. Other cutaneous findings include lipomas, fibromas, neurofibromas, and leiomyomas. The osteomas in the Gardner syndrome, the histopathology of the osteomas in the Gardner syndrome is generally of the compact type. Treatment is prophylactic colectomy is usually recommended because of the high risk of transformation of colorectal polyps into adenocarcinoma. Removal of jaw osteomas and epidermoid cysts for cosmetic reasons may also be indicated. Now, osteoid and osteoblastoma. These two are very closely related benign bone tumors that arise from osteoblast. They exhibit very similar histopathologic features. So they can be distinguished one from the other based on the clinical and the radiographic findings. Osteoblastoma is usually occurs in young patients. Young children under the age of 10 years or even 5 years are frequently affected. Males predominate over females, and the lesion occur most often in the femur and tibia. And if jaws are involved, there is a slight mandibular predominance. Pain is the most presenting symptom. The pain of osteoma is described as unrelenting and sharp, and it's worse at night. Clinically, the pain is relieved by non-steroidal anti-inflammatory drugs. Osteoma, the tumor, produces prostaglandins, and these prostaglandins result in the significant pain. Since NSAIDs are prostaglandin inhibitors, the pain in osteoma is relieved by this non-steroidal anti-inflammatory drugs. So coming to the size of the size of the tumor will be always small, and usually it will be smaller than 2 centimeter. Radiographically, osteoma typically appears as well circumscribed, round to avoid radiolucency. And at the center portion, the tumor nidus shows radio opacity. And this tumor nidus will be surrounded by a very prominent sclerosis of the bone. We call it as a reactive sclerosis. Then coming to the osteoblastoma. The most frequently affected sites are the vertebral column, long bones, pelvis, facial bones, and small bones of the hands and feet. Among gnathic lesions, there is a mandibular predilection, with most cases involving the posteriors. Most osteoblastomas are between 2 and 4 centimeter in size, but they can be as large as 10 centimeter. It also has dull pain, tenderness, and swelling. But in contrast to osteoma, NSAIDs usually does not relieve the pain associated with the osteoblastoma. . Coming to the radiographic picture, It is usually seen as a well-defined round or oval radiolucency with patchy areas of mineralization. Surrounding reactive sclerosis is less prominent in osteoblastoma than osteoid. Histopathologically, both osteoid and osteoblastoma, they exhibit irregular trabeculae of osteoid or woven bone, which is surrounded by numerous osteoblasts and scattered osteoclasts. So it shows irregular trabeculae of woven bone, and the loose fibrous stroma contains numerous blood vessels and hemorrhagic areas. So in the case of osteoid, the reactive sclerosis is very prominent. So in this micrograph also, we can see the prominent reactive, peripheral reactive bone formation. So at the periphery, there is typically a more prominent zone of dense sclerotic bone in osteoid than osteoblastoma. The vascularity also tends to be more prominent in osteoblastoma than osteoid. Now, aggressive osteoblastoma is a small subset of osteoblastoma that is characterized by atypical histopathologic features and locally aggressive behavior. These aggressive osteoblastomas exhibit radiographic findings similar to those of conventional osteoblastoma, but tend to be larger in size, like usually greater than 4 centimeter in diameter. Histopathologically, it is characterized by large osteoblasts with increased mitotic activity and sheets or lace-like areas of osteoid production. So this is the sheet or lace-like of area osteoid production. So when we see such a histopathological picture, this is very similar to that of a low-grade osteosarcoma. In low-grade osteosarcoma also, there is lace-like osteoid formation. So the osteosarcoma is a malignant neoplasm, so it's very important to distinguish histopathologically the aggressive osteoblastomas from low-grade osteosarcoma. So how do we differentiate? That is, in low-grade osteosarcoma, definitely there will be cytological atypia, atypical mitotic figures, and the growth pattern will be of the infiltrative growth pattern. Whereas in aggressive osteoblastoma, all the cytological atypia, atypical mitotic figures will be absent. So that is how histopathologically we differentiate aggressive osteoblastomas and low-grade osteosarcoma. So these are the differentiating features of osteoma and osteoblastoma. In osteoma, the size of the tumor will be less than 1.5 centimeter, whereas the osteoblastoma, the size will be much larger. It will be between 2 and 4 centimeters, but can be as large as 10 centimeters. In osteoma, the pain is relieved by non-steroidal anti-inflammatory drugs, but in osteoblastoma, the pain is not relieved, will not be relieved by NSAIDs. In osteoma, radiographically, around the tumor nidus, the sclerosis will be very prominent, but in osteoblastoma, it might not be prominent. Histopathology, the vascularity will be less in osteoma compared to osteoblastoma. So this concludes the benign osteogenic neoplasms of bone. Thank you.